Oh, there we are. Yeah, I can do the mouse. Excellent. So, ICU Telemedicine provides operational intelligence and support. And it provides prevention and management for adverse events by providing early recognition, efficient activation of response, effective monitoring of rescue. Escalation is proctored, meaning that an offsite team is there to add additional people to the team if necessary and when necessary. And it's a practical way to expand your ICU workforce. And this is particularly important for times when demand is high and during surges. So the first study that we had done was really a difficult study to do. I think in many ways we learned more from this study than from the other larger studies that followed it. One of the reasons for that was that it taught us a lot of the basic lessons about data. So this study was conceived with business people, administrators, physicians, data cleaning people named Karen Landry up there, who is the queen of clean data. And I don't think that the study would have been successful without everyone working together on it. One of the things that we learned about the data that came out of our clinical systems was that it couldn't be used directly. It needed to be looked at, it needed to be cleaned, it needed to be curated. There were 7 people in the data set that were born in the year 213 BC. We thought that probably wasn't exactly accurate. And this study really demonstrated, and the reason that we did this study was because if this expensive intervention didn't work, we were committed to taking it out of UMass. And if it did work, we wanted to figure out why it worked. And it did work, and we still don't know exactly why, but I'll show you the progress that we've made, and perhaps that'll set Jeremy in a place to tell us a little bit more about where we need to go in the future. One of the things we had a chance to do when we published our outcome study from a financial point of view was more carefully detail the timing of all the different things that we had done. We were very intentional about this. The primary paper lists all the stuff we didn't change. We had all the same people, same call schedules, all the same clinical practice guidelines. None of that stuff changed during this study. And these were the things that we had changed. It was our hope that we would be able to explain a lot of the variation in our outcomes by understanding these different variables. And in our database, we had, for each of these things, we had a way in which to include it in our predictive models. One of the key documents that we brought to the AHRQ Tele-ICU research forum that Jeremy Kahn very ably led was really this kind of data. So for the things that we targeted, stress ulcer prophylaxis, DVT, VAP, CRBSI, we made a difference. The strategy that we used to do this is we developed an evidence-based clinical practice guideline, performed a literature review the way you would for a meta-analysis. We agreed as a group, critical care group, representatives, both physician and nursing representatives from all our ICUs, about how we wanted to practice as a group, and we came up with a very efficient way to measure it. So you can see that for everything that we targeted, we made a difference in, and we included acute kidney injury, and we didn't target that. In retrospect, we probably should have. But there seemed to be some specificity to what changed. The bottom half of this very complicated graph here is just the odds ratios that we calculated for the different outcomes, hospital and ICU mortality, for those different things. And so the things that we tried to change, we changed, and the things that we changed seem to impact outcomes. One of the things that's been fascinating at this meeting is just how much emphasis there is on stress ulcer prophylaxis, which it turns out isn't strictly statistically significant in this. You might notice doesn't make a P of 0.05 in this. What was interesting about stress ulcer prophylaxis was that the p-value for the financial outcomes was strikingly high. So much so that we suspected it might not be true, so we started actually investigating that. And it turns out that having enough bleeding on day 2 or day 3 to be clinically significant results in a delay in your leaving the hospital, additional testing, sometimes invasive, and lots of additional blood tests. And it turns out that, for us at least, that turned out to be something that was expensive. So Jeremy advanced the field by saying, okay, I get it. I buy it. That if you go and you have better practices, better rates of best practice adherence, and you can eliminate those complications, it'll lead to improvements in mortality and length of stay. I get it. But the hub and spoke model of telemedicine, you don't necessarily need to have all that stuff to do it. I'm going to come up with a more efficient way to do it. So he had an off-site nurse that was doing these same things and really had great results. Now, I'd like to tell you that all the effort we put into this really gave us a commanding understanding of how Tele-ICU works, but it turned out that wasn't the case. We were so excited when we saw these initial p-values, we really felt like we had a good shot of explaining a lot of the variance in our outcomes based on the things that we measured. And the long and the short of it is, while we were able to do these analyses, and it took a while for me to learn how to do them correctly, and the standardized coefficients matched almost perfectly, that at the end of the day, we were only able to account for about 30% of our improvement in mortality, and the length of stay data was similar by the best practice and complication metrics that were in our database. And when we put a large number of additional variables from our database, the models didn't seem to get a lot better. So at the end of the day, we were pretty disappointed because it really indicated that we didn't have a good handle on exactly how this was working, although it did show us that best practices are important. So the next thing that we did, and many of the people in this room contributed to this, was we went to the American College of Chest Physicians, and we asked them to sponsor a survey where we would go out and we would try to understand for everybody else who implemented a hub-and-spoke model Tele-ICU program and elected to collect data in a before and after fashion, we wanted to find out what things in their intensive care units changed that weren't really part of our initial study. So we convened, Michael was part of this group, Steve Furman was part of this group, Bill Hansen from UPenn was part of this group. I think that Teresa Rincon was in the group and Sue Gorin was in the group. It was an interprofessional group. And we identified 51 things that could be measured by a survey. There were ICU level variables that might be important. And I'm delighted to tell you that we got 2 surveys back from 100% of our target sites and 83% of our overall sites, which was an indication of the interest that we had in this particular subject. So we were interested in what changed at each of these sites. So the next step was to go out and to collect data from all of the different healthcare systems that had done before and after studies. And this isn't just the outcomes data, this is the actual patient level data. So we were able, after we cleaned it, this was also, Karen also went above and beyond to clean this data set. We ended up with 118,990 records in 60 ICUs. And this data set was not as clean as our medical center data set, primarily because we didn't have unfettered access to the primary data, so that there were a number of apparent discrepancies that we weren't able to resolve in this data set. But nonetheless, that allowed us to look at the outcomes for all the different centers, both for length of stay and for mortality. One of the things that was striking about this was that if you just looked at individual centers, many individual centers didn't pass the test. Their 95% confidence intervals overlap with unity. And that was particularly true for the mortality characteristics. So that told us that there's a lot of variability among the different installations. And if this had been published as A through R individual studies, most of them would have been negative, and you'd go away saying, "Oh, well, that's not statistically significant." That's not what we did. We took all of their original data, and although this is presented in a forest plot kind of a way, it's all primary analyses, and we estimated the effect of this intervention. So there is some controversy about how to best model this, and to avoid going there, just take a look at the unadjusted hospital mortality. So 10.8 to 9.9, alive or dead. And if you believe the Lee study from the Philip Lee study from San Francisco, that would correspond to about 5,000 people a year that are alive who had this intervention compared to those that aren't. Now, because we had the outcome for every single healthcare system, and because we had a validated instrument to measure what changed, we were able to go back and say, okay, well, what did we miss? What did we not know about when we did our medical center study that we now know about because we've looked at this larger data set? And so the things that when we compared the top performing to the bottom performing ICUs, higher levels of intensivist involvement, more effective ICU committee, more likely to respond to alarms in 3 minutes, more cases reviewed within an hour by an intensivist, more likely to have sign out by bedside providers, review of ICU performance data in real time, reported higher rates of best practice adherence, and more likely to perform bedside and offsite team documentation in a system available to both. Those were the things that separated the top performers from the bottom performers. And in every single case, the way that common sense would tell you it should go, the more effective your ICU committee, the better outcome. There wasn't a single thing that went in the other direction. The disappointing part of this, the exciting part was we found stuff. None of that stuff is stuff that many of those items were things that I couldn't have found in my single medical center study. So this was a step forward, but it was also really disappointing. It was disappointing because there wasn't any one thing of all 51 things that we thought of, there wasn't any one thing that's the magic thing. If you just do that, you get all the benefit. It didn't work out that way. And it turned out that there was a lot of variability. Some people, if before you made the intervention, you already had a really top performing best practice program or a really good performing committee, or you had good access to your data, then it's not going to get better. So what we ended up doing was we then added the intensivist case involvement increase, the population management tools, and essentially workforce intelligence, operational intelligence piece, the interprofessional rounding piece, and the timely responses to alerts and alarms. And when we did that, we saw a dose-response relationship between positive changes in those things and how much you improved in terms of both your mortality and your length of stay. This is Jeremy's cut at the same kind of an analysis. He was able, and I couldn't for reasons I won't go into, display it in a little bit more easy to follow way. In this chart on the right-hand side, you can see that the better performing ICUs are on the left and the worst performing ones are on the right. And he correctly pointed out that like we did, that there's a huge amount of variation, and there's some places, maybe more than you'd like to think about, who implemented this intervention and got worse results instead of better results. However, the subset and his estimates of the improvement and mine are the ones we did are a little bit different. One reason is that in this example, there are healthcare systems included that implemented it without doing any before and after measures. And we didn't take those into our study because we were interested in healthcare systems that implemented this technology because they wanted to try to change behavior and make things better. So here he quotes, ICU telemedicine adoption was associated with a small relative reduction in 90-day mortality, odds ratio 0.96. Again, applying this to the Philip R. Lee database at Stanford, that corresponds to about 20,000 patients a year who are alive because of this intervention. At the same time that we were exploring the effects at our medical center, we started to use, at the time that we finished the clinical study and we're starting to do the analytics, we became aware that we could better support our community hospitals by doing logistical functions, that we had lost control as a medical center in a region over where our patients went. They often got schlepped around based on physician convenience and not true medical need. And what was really a problem was that many patients were coming to our major medical center who simply didn't need to be there. It was inconvenient to their family. The patients didn't like it. They wanted great care closer to home. So we started interacting with the emergency department physicians in all of the hospitals that are our main referral base, and we developed a two-way system where patients that can be cared for in the community are cared for in the community, and those that need to come to the medical center can come to the medical center. The main game changer here is that if I take that patient into a community hospital ICU, I am responsible for evacuating them out. And if they need to evacuate them out in our system, I'm the person that's on the phone anyway in our logistics center. So this allowed them, after we signed off on it and made some agreements about who had a secure airway and a good IV before they went up to the ICU, this allowed us to really keep more patients in the community. And de facto, we have regionalized our region, our medical center, and have many more patients in the community than we would have otherwise. Who are these patients? Well, we crosswalked all the DRGs. They're patients with heart failure, respiratory failure, sepsis, diabetes, GI hemorrhage, acute MIs. And in every category, the community hospitals took care of more patients, and for any individual DRG, the average Apache score was higher. And this translated into substantially more revenue for our community hospitals, which they desperately needed. And in addition, it provided greater professional revenue and also third-party reimbursement at our medical center because we were no longer full of patients low acuity patients that we weren't paid as well for and didn't need to be there. In addition, it saved the third-party payers about $10,000 a case. For every case that was managed in a community that would have otherwise gone to the medical center, the difference in our ABC accounting was about $10,000 a case. Now, I'd like to tell you that this was also an amazingly shining success, but it didn't really work out that way. It turned out that we have 5 hospitals that we were supporting at this time, and this worked great in 4 of them. But there was one hospital where there was a great deal of resistance to adoption, and it was purely done on a physician convenience basis, very poor communication, and they had just rotten mortality outcomes. And I think it's the main reason that when I met with the Democratic chair of the House, the Massachusetts Healthcare Committee, that the state decided they weren't yet ready to invest, make the capital available to allow this technology to go statewide. So our approach to this is something that we learned from Tim. And Tim, for a long time, has been a great advocate of amazingly high quality NPs and PAs as being able to give high quality critical care and standard treatment. And ultimately, we ended up training at our place in a similar program to the one that he has at Emory, some NPs and PAs who are now taking over for the daytime intensivists at night, sometimes hospitalists, and they've now got decent outcomes. So that very much validates what you had shown us, Tim. This is Tim's study. At least in my study, Tim, I got to choose the analytics and do the stuff. I got audited by PricewaterhouseCoopers, but in your case, I don't think you got a chance to do this. They all came in and did the analyses for you. And if I understand correctly, what they found, or what you found, was for every case there was $1,486.26 less expensive for good care versus bad care. So our hats off to you for doing this. I think it's a major advance in the field. This brings us to our financial outcome study. One of the things that happened early on was a number of executives that were interested in the financial outcomes pointed out that due to the financial accounting rules, that things change year to year, case mix index changes year to year, and that it would be really hard in a 1 or a 2 or a 3 year period to really be certain that you've made a financial impact that was durable and sustainable. So we elected to run our financial analyses out of a much longer horizon. We learned quite a bit from doing this, and I'll show you a little bit about what I think the main take-home points are for that. When we looked at the numbers, and we had these numbers for the original paper, the editor of JAMA called me up and said, we'll publish the paper, but you have to keep the financial stuff out of it. We think it's too biasing and it's not quite ready for prime time. So that turned out, I was quite disappointed, you can imagine, when they said that, but it turned out to be a blessing in disguise. So if you look at the top line, this is our case volume, 4,752 cases. A couple years later, 5,735 cases. A couple years later, 6,581 cases. This peaked at 7,300 cases, and then we got epic and saw a 27% downturn. Length of stay, similar to what we reported in the primary paper. Started out at 10.4, went down to 9.7, went down to 8.8, went down to 8.3. So continued improvement over time. And because we were seeing more cases and we were profitable per case, and we could do them at lower cost, this turned out to be quite a financial boon for the institution. Rather than being 7.9 million to the positive, we were over 60 million to the positive. So one of the key messages, if you haven't seen the books in your healthcare organization, that you should go away with is that bad critical care is incredibly expensive and good critical care costs less. So if you can improve your metrics, your care of patients, you can make a huge financial difference for your organization. So this describes all the different 3 phases of this longer study. We had laid this out pretty much at the ARC sponsored research agenda, and I'm delighted to share with you today we've largely completed what we committed to at that time. All of it's done without extramural support. So at the very start of this, on the left-hand side where it's all red over there, before we started this study, we agreed on our clinical practice guidelines, our physician's orders, and not to change anything for this period. So it was a CPG, order sets, metrics, reports, regular meetings. So that's what we implemented. Before we started, we had a paper and pencil way to do best practices, and we were pretty good at it, 80, 85%. But when we did this, we went to 100%, and we got better. So you can see initially in the red line here that our hospital volume starts to go up about the time that we implement, and it stagnates. After that, we started doing the logistical moving of patients around. In the first interval, it was just for our medical units. In the second interval, it was the medical units plus the surgical units at night. And in the third interval, that's the third one in from the right-hand side. That one, that was where we were when we started doing all of it. As we were moving patients who didn't need to be in our ICUs out to get patients who did need to be in, our length of stay fell. Now, the green part here is fascinating also, and this didn't come out. This is another thing that just didn't come out the way we thought it was going to come out. So during this study, all of us held our breath and said, okay, we're not going to do any quality improvement for the whole time of this study, which was about 1.5 years or 2 years. So by the time we called the study off, we closed the clinical part of the study, there were a whole bunch of quality improvement projects to be done. We did 51 of them in this interval here that's reported, and since there we've done 100 more. And each one of these projects, you can read about them in the online supplement. They had its own P&L, and we implemented 96% of what we decided to do, and in almost every case, we're able to eliminate ordering of inappropriate lab tests, and we're able to reduce drug costs and those sort of things individually. But this did not change our cost structure, even though we were successful. And it's really because so much of our cost structure is related to our labor costs, particularly nursing labor costs. We have the top 5% of the country for nursing salary. And even though we made huge efforts to control the non-labor costs, overall it didn't make much difference. So back to Donna's question, why do you need a Tele-ICU? I'll give you 7 patient-centered reasons. 1, help is better than no help, and all of us need help when it comes to patient care. Intercepting medical errors is better than patient harm. Tele-ICU systems provide accurate and timely operational intelligence. Management based on accurate real-time intelligence reduces variation in care and improves outcomes. Off-site support provides surge capacity when risk for error is high and resources are scarce. Tele-ICU prospective detection systems detect direct expertise when and where it's needed. And lastly, Tele-ICU makes high-quality critical care available to more unstable patients. I'd like to thank you for your time and attention today, and for those of you that would like to view the financial side of the argument for having a Tele-ICU, Dr. Buchman was kind enough to allow me to write in the bottom center of this ICU Telemedicine Financial Analysis of a Complex Intervention paper where that is summarized. The final comment that I would leave you with is that this is still not well understood. We need to study it more, use better methods, and creative techniques like those that Jeremy's doing so that we can understand more of the provider-level characteristics of success and not success. Thank you.
Sir, are you ready to put the next set of slides?
I could have introduced you if you wanted, Donna.
Oh, okay. All right. Okay. My name's Donna Armaignac, and I'm the Director of Best Practice for Telehealth and the Director for the new Center of Advanced Analytics at Baptist Health, South Florida. And I'll share with you a little bit about the characteristics of the organization when the slides go up. Oops, did I do that? Okay, here we go. Okay, my part of the talk is going to focus around why we should expect to maximize positive patient care outcomes through telehealth. I have no disclosures other than I work for a beautiful organization and we have lots of pineapples and palm trees. And we have 10 plus hospitals at this juncture. Our coverage area is from mid-east Florida down to the Keys. And we also have a coverage area of the Caribbean, Central America, and a relationship with Royal Caribbean Cruise Line. These are the overall objectives of the session. I'm going to discuss the benefits, clinical benefits, operational benefits, benefits to patient care outcomes. Jeremy is going to be discussing challenges to empirical designs, and Dr. Ries will be discussing value of this investment. I'm going to provide to you some cases, some use cases concerning where telemedicine provides tremendous affordances, both to the healthcare organization and the patient, and how it strengthens integration of clinical services. Okay, the first use case. And all of these are persistent challenges that I'm fairly certain apply to all of our intensive care units. The first being placing patients in the proper place for their acuity. You know that we have patients that come to ICU, low risk, just for monitoring, and we also have patients that are high risk that may be held over in the ED or they may be cared for on the wards, and it's not necessarily the best place for the patients. And so progressive care units, which may be called intermediate, transitional, they have a variety of different names, high dependency, but the overall umbrella name is progressive care. And our organizations want to know under what circumstances we can provide improved quality and safety and also perhaps reduce cost. So we set forth to examine the effect of teleintervention in the progressive care environment. We examined standard established quality outcomes, mortality, length of stay, survival. We did severity adjustments, and we utilized standard AHRQ classifications of organs or diseases. Okay, on your right-hand side, are primary care patients, and the other side are secondary care patients. Primary are those patients that were admitted to the progressive care unit as their principal admission. And secondary progressive care patients are those that went to the progressive care after their ICU stay. Traditionally, we'll call them step-down patients. The total sample is about 20,000 patients. The primary progressive care, you'd make note, is they're a high volume capacity. They're, account for 16,000 of these 20,000 patients, whereby the secondary PCUs are only about 3,500. Okay, concerning the severity of illness, you'll make note that the distribution of risk of mortality and severity is going to be higher in the treatment group. Now, the treatment group is a teleintervention group, and they're in the green color, and the control group is the gray group. And as I said, the higher severity of illness happens to be in the treatment group. Similarly, for risk of mortality, the greatest risk happens to be in the treatment group. Now, this is the difference in mean progressive care unit duration between the groups. Significantly less time in the progressive care environment in the treatment groups, regardless of primary or secondary. And this happens to be the most frequently occurring length of stay for the progressive care environment. With the concomitant tele-intervention duration. In order to come into the study, they had to have at least 24 hours of PCU time with concurrent tele-intervention time. Generally speaking, they were in the PCU for about 2 days, and they had pretty similar amounts of tele-intervention. Now, mind you, there's a little bit of crossover between the electronic healthcare systems. One is general EHR, and the other is the tele-EHR. So they're not going to match exactly perfect. Okay, this is the severity adjusted mortality between the groups. And once again, you'll make note, primary or secondary, the mortality is much better than predicted in the treatment groups. It's almost too good to be true. All right, so when you do a lives saved calculation, once again, you have many more lives saved in our tele-intervention group. To Craig's point, we can save lives. This happens to be the survival analysis, unadjusted and adjusted. And the patients, regardless of whether it's adjusted or unadjusted, they have about a 20% survival benefit. This is for the primary group right here, and it was published in Critical Care Medicine last year in 2018. These data right here are just for the primary group. Survival analysis, looking at the secondary group, there was no significant survival analysis for the secondary group, only the primary group. Okay, here we have cost per day. Cost is a challenging thing to examine concerning tele-intervention. In the primary group, there was a good amount of cost savings. In the secondary group, there was not. That could be because this is on total length of stay, and these patients were in the ICU before the PCU. Could be a number of different reasons. But if the patient was in the hospital less than 5 days, there was really no difference. If the patient was in the hospital for greater than 5 days, the treatment group, they cost more money, but they also lived. Okay, this is demonstrating that the negative cost incurrence is taking place in the most severely ill patients. So the patients that are less severely ill, we're having some advantages. All right, so obviously strengths and limitations. We didn't have the ability to control for physician selection of choosing a telemedicine approach for their progressive care unit patient for choice reason, and also the other reason they didn't really have a choice, there wasn't an equipped bed for them. This may be actually a benefit of selection bias, because what it enabled us to have is an appropriate concurrent control group, because we had patients that were quite sick, and if there was no PCU telemedicine equipped bed, they didn't have the choice to choose the telemedicine or not. We had a large group of patients. We did the best analytics that we could apply to this method. We did pool data from many hospitals, and we had equal distribution of deaths among bed capacity. So we're fairly confident with this data. When we looked at cardiology specific patients, which is the greatest amount of progressive care patients. And we had a significant mortality benefit. We had a significant survival benefit. And you can see that we had, in the group that had acute MI specifically, they had a tremendous survival benefit of 54%, all of these being significant. So the whole entire cardiology group had mortality benefit, survival benefit. The acute MI patients, they received the greatest benefit. In this particular sub-analysis, there really wasn't any difference in LOS or cost. But it gives you an example of a disease-specific application of the tele-intervention had great impact, great positive impact. Okay, going back a bit. This is just the graph of the Kaplan-Meier looking at the survival analysis between the two groups. And as I already stated, we had a significant, remarkable benefit. Okay, so this is Tele Solution number 1 to the persistent challenge that we have of, ICU, PCU bed utilization and, putting patients in the right place for their level of acuity and whether or not the tele-intervention affords people benefit and also affords operational efficiencies. And I believe that our data is demonstrating that. Now we're going to talk about persistent challenge number 2. I'm going to go forward one slide and then backwards. Okay, now things that even Craig mentioned this as well. Emergency department surge, patient experience in the ED, door-to-doc and door-to-decision in the ED. These are all extremely important metrics for emergency practice and also for patient care experience. So if I move back here, it's the number 1 concern for both patients and organizations. EDs have specific metrics that they're shooting for. I won't redo the exact times, but I'll just let you know that, they're striving to achieve the least amount of time door-to-doc, door-to-decision, and also when we have ICU patients waiting in the ED. Okay, so when we examined these ED patients that had teletriage, the door-to-doc time overall was improved by 25 minutes. In the pain categories, whether it be chest pain, abdominal pain, other pain, they had significant benefit for door-to-doc. In the overall group of door-to-dispo, we didn't see the same benefit with the exception of we had benefit for the chest pain. And the reason we're not seeing as good a benefit in the door-to-dispo is because in Florida, ED physicians, the tele-physicians can't do a final dispo. They have to turn it over to the on-site ED physician. And of course, that's going to produce additional, delays. All right, we examined it by acuity level. Most of the patients were acuity level 2 and 3, ESI scoring system for the ED. Once again, we saw the greatest benefit for the patients that are door-to-doc as opposed to door-to-decision. And so this is Tele Solution number 2 to the issues that we have in the ED. It was a real-time addressment of addressing surge and volume overload in the ED, which is a major problem because this causes problems throughout the entire hospital, as we all know. One of the things that was quite remarkable is the patients who received the tele-intervention and went into the tele room, they felt like VIPs. They felt like they were plucked out and put into a special room and received special attention. Additionally, we have these carts that they're remote carts in the ED that when a patient is, a dispo is an ICU patient and we don't have an ICU bed readily available, they're managed by the Tele-ICU through this cart. So obviously, Tele Solution number 2 is provides great affordances. Okay, I'm going to introduce something called the Embers theory. This is Eddie Martinez, Embers Theory. He is our Associate Medical Director, Telecritical Care, Telehealth, and he coined this term. I'm going to introduce some concepts concerning LOS and cost. All right, so in our organization, we have some hospitals that are principally managed by 24/7 bedside intensivists, and we have some hospitals that are principally managed by the tele-intensivist. And those that are managed by the tele-intensivist, of course, they have more tele-intensivist interventions. There's a reason why I'm bringing up this topic. All right, so this slide, what we're looking at here is total LOS savings per ICU patient of the higher risk patients greater than a 30% mortality. And the black is the intensivist run hospital, the black is the bedside intensivists, the gray is the tele-intensivist. And you will make note that the tele-intensivists are providing many more interventions in the locations where there are not bedside intensivists. That's okay, that's what you would expect. But make note that the severity adjusted mortality, particularly, which is on the bottom, is pretty much even. So these physicians in the ICU with the highest risk patients are receiving the least amount of tele-interventions. But when you go to the lower risk mortality, you're going to see that the severity adjusted mortality is better in the hospitals that are managed by the tele-intensivists. And there is an LOS savings, and you can infer cost savings. So we thought that was quite remarkable. Mind you, this is not a statistical analysis, but it's an interpretation that our patients who are low-risk mortality managed by the tele-intensivists have improved severity-adjusted mortality and LOS savings. And why we call it the Embers Theory is that we believe that the intensivists are taking care of the fires and the bedside intensivists. And the tele-intensivists are taking care of just moving routine standards of care forward, keeping pace with all the best practice interventions, doing what they're intended to do. And we are seeing that the tele-intensivist run hospitals with the greatest amount of tele-interventions are doing much better than the 24/7 bedside intensivist model. Okay, and when you combine both the high severity and the low severity, you can still see here that the areas that have the greatest proportion of tele-intensivist intervention also correlate with better severity adjusted mortality, better LOS, and cost avoidance. All right, now this is another area that Dr. Martinez is examining. That would fall under our embers theory, that the tele-intensivists take care of the embers, whereas the bedside intensivists are probably busy taking care of the big fires. Right here, we're looking at vent days that are greater than predicted. And the black area is the 24/7 bedside intensivist area. So they have a lot more opportunities to get patients off the vent. When you look at what this calculates to in dollars, it's a lot of dollars. And I'd say that severity adjusted vent days is, in our organization, our greatest opportunity. And this is a perfect target for the tele-intensivist to move along, vent liberation. All right, so the Tele Solution number 3, if we ascribe to the embers theory, we're going to improve outcomes with our tele-intensivist model. Okay, so what's next? What I've learned as we've transitioned from not only a tele center to a center of advanced analytics, our traditional ways of examining things are not sufficient. It doesn't matter if we have superiority with one intervention or another. We must demonstrate incremental cost effectiveness ratio, ICER. Folks may be familiar with this, and it's looking like clinical folks have to develop economic skills. And this is an area that is not within our domain. All right, one of our biostatisticians put together this slide concerning cost effectiveness ratio. I'm just going to go through it and then explain it. Okay, so we're traditionally looking at the effectiveness of one treatment or another treatment, via, the old methods, and there's obviously a cost associated with whatever intervention that we were applying. In this case, it's the tele-intervention. And according to the ICER model, if we have anything that's below the diagonal plane, that would be a positive incremental cost effectiveness ratio, whereby we have the highest effectiveness with the lowest cost, which is the goal. And I believe that our aim is to demonstrate this with our tele-intervention modeling. Okay. Now, this is another challenge, persistent challenge, and it seems that we're addressing this more and more. I don't know if I'll have enough time to go through all of this, but I will just share with you that the tele center that we have was the Emergency Operations Center hub, and we had no hurricane-related deaths when we experienced Irma, about 2 years ago now, is it? One or 2 years? Okay, so the center did evacuations. They took care of, at our healthcare system, the doors are not closed to anyone, whether they're patients, families, staff, the families of the staff, anybody. The doors are not closed to anyone. So the telecenter managed all of these processes. They managed the evacuation of hospitals. They managed when ORs had a bed, or the cases could go into the ORs. They were essentially the Emergency Operation Command Center. And in the interest of time, I'm going to move over to the last. I won't go into the details of all of this. All right, this right here is the Challenger shuttle disaster, right? And somebody shared this with me recently because it's a demonstration of why data visualization and advanced analytics and these design principles are crucial, and they are fulfilled through the Tele-ICU solution. Okay, so I am not taking an engineering perspective on this. I'm not taking a Morton Thiokol perspective. I'm not taking a NASA perspective. I don't know anything about any of those things. This was how the engineers examined the shuttle launches. Each of them had 2 rockets. They recorded ambient temperature, and they recorded the degree of damage or erosion, and you can see the different colored, degrees of erosion. And they put their visuals in consecutive order of launches, and putting them in that way, you really can't draw any visual conclusions. When they did post-analyses of this disaster, a gentleman named Tufte published a book on visual procedures, and he put the launches in order of ambient temperature as opposed to the launches themselves, and he was able to start seeing a relationship. And when he plotted the degree of damage against the ambient temperature, something started to emerge just by changing the visual analytic. And you can see that there was problems with the shuttles, high-level damage to the shuttles, even at higher temperatures. But you can see that the exponential issue of shuttle disaster occurred, and it was at the lowest of possible temperatures, and that's what the temperature was on the day of the launch. Like I said, I'm not doing this because of decision-making or anything that occurred during that launch. I'm only doing this to demonstrate how data visualization is powerful. Now, fulfilling the promise of healthcare technology. I used to think our beautiful paper electronic health record that we could plot 24 hours and we could see 24 hours at a glance, but all of our data points were within their unit, were plotted along. There was no interrelationship. We might be able to see an interrelationship, but we didn't have any multivariate analysis. We didn't have any relationship between the variables. We weren't able to see if something occurred upstream had an influence of what was going on downstream. And the principles of this gentleman, Tufte, are telling us that they're very valuable for us as clinicians, because we're getting data thrown at us all the time, and if we can have data that's visually intuitive, and we can take care of the patients utilizing these visual cues, we can do a whole lot better. And these types of things are afforded with the Tele-ICU platform. And let's see, okay. All right, lastly, I would never be able to tell you all the different wonderful things that Tele has done for Baptist Health, but it's across the continuum of care. And every area that Tele is applied is afforded benefits, from an operational and a clinical, and we're starting to see from a economic perspective. We have new programs popping up every day. So lastly, why should you expect Tele to maximize positive patient care outcomes? I hope I've demonstrated that for you. It's been our experience, and I believe the experience of lots of other folks that have a Tele center. Thank you very much.
Thanks, if you could. That's perfect. Thanks so much. I was asked to speak about the Afferent Arm, and I'm going to try to persuade you that the telemedicine specialist is really a safety officer, and we need to start thinking of them in very different terms. I don't have any financial relationships. I will tell you that Emory's a Philips ICU customer and an Excel Bedmaster X customer. Both are implemented in our Tele-ICU solutions. I'll tell you I'm editor-in-chief of the two journals. I'll tell you that part-time I work for the United States government. And in both cases, my opinions today are personal and don't reflect positions. The United States government, agencies thereof, any university or vendor, they're my opinions. The traditional approach to sense-making in the ICU looks something like this. There's a chart, which you can see in the center there. Somebody's holding a clipboard with a bunch of labs on it. There's a to-do list, and if you actually count, there are 13 people in the picture. There's a lot of opportunity for error in information transfer. Now, about 40 years ago, the first EHRs surfaced. On the left, a traditional chart. On the right, the first electronic system. This was John Brim's MTech system. We thought we were in heaven. We weren't. We got better pictures. We were still writing things down on pieces of paper. It didn't work out as well as we'd hoped. About 10 years ago, we published a paper in the journal indicating that from the EMR or from the piece of paper, about 20 to 25% of what was being communicated was simply wrong. Well, we should have gotten better with the computers on wheels, smaller, lighter, and faster, but it didn't help as much as we expected. 2017, we published this paper from Catherine Artis and her group in our journal, and it said despite a structured interprofessional rounding system, we hadn't gotten much better, and there was a lot of data omission going on. So there's a problem, just getting the information to make the right decisions. Now, it's clear that different approaches are needed, and probably it starts with everybody looking at the same view at the same time, so you're actually having a conversation about the same thing. But what should that common view look like? A picture of the ICU, you've got your clinical databases running behind it, you've got your chart there, you've got all the stuff that's going on the waveform. Clinical assessment, data integration, and synchronization, I think all matter. Maybe this is the sort of thing that's needed, where you have, starting from the medical device data on the left there, plug-and-play adapters where the data automatically drops into the aggregator. The nurses actually have a systematic way of getting the phenotypic data in, and then you've got all sorts of decision support and visualization tools driven probably by artificial intelligence, machine learning, deep learning, and so forth, all coming down to a single clinician-centric data visualization display. That probably is what's needed. This is what we have at the moment. We've gotten closer to this by at least having all the screens in one place with team theaters in our ICUs. But this is still on the scale of a single unit, and the views are neither easy nor integrated. This is still not a great way to take care of patients. And we knew this when we started setting up the idea of the smarter ICU. On the lower left, you see a little picture that actually emulates what was drawn in the figure, but I call your attention to the upper right, which is really the Tele-ICU environment. And the question is, how does this actually make us smarter? Well, this is air traffic control for the ICU. It's critical care at the population scale. As both Craig and Donna have alluded to, the idea is to find the patient who's sick and do something about them before the ember smolders into a full-blown blaze. We're safety officers. We're not there to supplant the people at the bedside. We're there to support them, and we're there to help them do their job as best they know how. So the emerging role is safety officers and their responsibilities, which really look like this: to detect an anomaly, to track the anomaly, to classify the type of anomaly it is, to project it into the future as best you can, and make a decision if something needs to be done or doesn't. If something needs to be done, someone is assigned the task, they act, and you evaluate the outcome. That picture is no different than what you would see in a combat command center on a naval warship. In fact, that's where I took it from. So the question becomes, and I think this is the next generation question. You've already heard that Tele-ICU helped you detect stuff. The question is, can you predict it? On your left is a picture of a group of young physicians standing around a attending surgeon in an ICU who at the time still had hair. That would be me, and that would be the 1980s. You can see the glass bottle in the foreground, the films in the background, and that was sort of how we made predictions. It didn't work that well. We probably needed to do it digitally. So what we were doing at the bedside at that time was basically describing, this is what's happening to the patient, and basically we'd take that together and we'd look in hindsight and say, we've seen this before? Yeah, I'm not sure, but maybe we ought to do something. Well, with the team theater, we're getting closer to real-time diagnosis. If we look at the stuff, we can probably see the alerts in real time. But that's not where we want to be, is it? We really want to be in foresight with prediction, what will happen next, and then, of course, how can we change what's going to happen next? Defining, surviving, forecasting, and preventing critical illnesses and complications is the only way we're going to make a quantum leap forward over the next several years. So other industries have been disrupted when transformed from analog to digital, whether it's designing aircraft, integrated chip design, stewardship of the national stockpile. Predictive medicine needs to go the same route. And the idea, of course, is to find the patient. I've used sepsis here as the example, but it could have been heart failure, respiratory failure, pick your illness. Find the infected patient prior to symptoms, treat it early, mitigate the dysregulated host response, and prevent the organ dysfunction. Well, so this is what's going on. I've picked up the Emory program first, but I'll show you some others. This is now funded by Drive. What you're seeing there is the threshold time to sepsis prediction. When we did this initially, we were able to identify about 85% 4 hours before the bad event, and with deep learning, we're up to about 89 or 90%. So it's possible to use artificial intelligence, deep learning, to peer into the future and hopefully to intervene sooner. It does beg the question, who should see these predictions? Now, the promise was there when we heard about Watson and all these deep learning programs. You saw a bunch of editorials like this. You've seen most recently in Nature, the artificial intelligence clinician can actually tell you what to do and do it better. But it's a question of who sees it. Many people are taking the machine learning, deep learning approaches to prediction. This is the effect of a machine learning-based severe sepsis algorithm on patient survival and hospital length of stay. It was a randomized clinical trial. It was small. It was actually very effective. I'll show you the data in the next slide, but what I want you to read is what's in red. The algorithm predicted severe sepsis for a given patient. A phone call was placed to the charge nurse on duty. They separated the adjudicator from the person at the bedside. They made a decision not to dump more information on the bedside clinician who's already awash in alerts and has no idea which one to believe. And their data were pretty good. The error bars don't really overlap in terms of in-hospital mortality. Now, it's a small study, but it's the sort of thing that you would say is promising. So you end up with, what do you want to do in your Tele-ICU? You can have an artificial intelligence system which is tireless, it has a perfect memory, never gets ticked off at you, but unfortunately has no common sense. And then you have human, it passes for intelligence. It fatigues, gets sick, it's forgetful, it gets moody, but sometimes it has some clinical judgment. We actually need that balance in alert adjudication. So it's sense-making of what the computer is seeing. So if I'm there in the EICU and the other intensivists are in the EICU, who's actually there at the bedside? Well, the system is, at least in our program, we have 150 advanced practice providers trained up in critical care throughout our system. And it's the bedside nurses and the APPs who form the care dyad. They are the immediate effector arm. Now, that does two things. It first gives a second layer of smart people. So if I say something silly, they'll say, "Are you sure you're talking about the right patient?" And I'll tell you at 2 o'clock in the morning, I've made that mistake. But having a smart group of effectors is no less important than having good systems and good adjudicators. And this is what it looks like. For those of you who haven't seen the Tele-ICU environment, you've got the screen, you've got the APP, you've got the nurse, and you've got the nurse in the EICU. It works well. Moving forward, if this is such a good system, we're going to have to find people who are going to do this. And our experience is that given the age distribution of both nurses and physicians, all of whom seem to be aging at a fairly rapid clip, we need to take advantage of the accumulated wisdom in aging bodies. And our experience is to get people near the cusp of retirement, transition them to the EICU role, and retain that knowledge for a few years more than might otherwise be useful. So here in the Telehealth Center is precisely where. Our experience is that the traditional model, having the bunker or the command center within a few miles or a few hundred miles, works really well, but it can be done pretty much anywhere. And when you start talking about provider joy and satisfaction, it may not be a good idea to co-locate the night work with the telehealth providers who are doing the night work. We shuttle a doctor and a nurse to the other side of the world, to Perth, Australia, where they're exactly 12 hours off of Atlanta. So these pictures are taken at 3 o'clock in the morning in Atlanta, and they're perfectly happy to be up and working. And why are they perfectly happy to be up and working? Because when their shift is over, they go out to the beach. I'll show you that picture in a moment, but what I'd like to leave you with are just a few things. As the title of this session telegraphs, telemedicine is medicine, tele-ICU is ICU, telecare is care. Tele, in and of itself, simply removes the restriction that all the caregivers have to be co-located. Removing that restriction is more than a matter of convenience. It enables task reallocation on a previously impossible scale. At reallocation can actually reassort the tasks across geography, as I've shown you, and expertise. You don't need an intensivist in every unit at the bedside if you've got great effectors doing their thing. Craig showed you the data, $1,486 per patient we touched, saved. But creating value from that reallocation will not occur automatically and cannot occur in a vacuum. It's going to require human expertise, machine expertise, and most importantly, the blend, the distribution, and the interaction between the human and the machine are what I think actually matters most. So these are two sunsets from Cottesloe Beach where we go after we've had our shift. No, these images are not enhanced or manipulated. There's no Photoshop. That's what it really looks like at the end of shift. Thank you very much.
Thank you, everyone. I'm Jeremy Kahn from the University of Pittsburgh. It really is an absolute pleasure here to be here today and be part of this truly incredible panel. I've been asked to talk about the research side, and I re-engineered my talk title a bit. The way I've decided to approach this is to give you guys an overview of what I'm sort of calling the 3 phases of ICU telemedicine research: past, present, and future. And along the way, hope to give you some of the insights that I've gained over the last few years as I've been thinking more and more about this, and then hopefully build on some of the themes that we've already heard about today from the other speakers. So my disclosures are pretty simple. I'm employed in part by a large health system in Western Pennsylvania that uses a variety of telehealth solutions, and I'm funded by a variety of federal agencies, including some funding from the NIH specifically to look at ICU telemedicine. Just start with what I want to call a tractable definition of ICU telemedicine, because that's the very first thing you have to do when you're thinking about research, is just define what you want to study. There's lots of great definitions out there. I'm calling it use of audiovisual technology to provide critical care from a remote location. It's very broad, but I think part and parcel of that definition is this increasing realization that this is more than just care delivery, and I think almost every speaker has hit on this thus far, that what we're really talking about is, in a way, transformation of the ICU organizational environment. And you really, when you think about research and studying ICU telemedicine, have to approach it from that lens. Okay, so here's a little bit of an outline. These are my 3 phases that I came up with as I'm thinking about this topic. All right, we started with, does this work? We moved to phase 2, where we are right now, which is how and where does this work best? And then I'm going to talk a little bit about, can we make this better? Phase 3, where are we going? What do I think the research that still needs to be done is? So I'll start with the first phase, the phase we're out of now, the does this work phase. So the initial era of research, this is the research we all remember from the 90s, was characterized by these single center before-after studies, right? We didn't have telemedicine, now we do have telemedicine. I'm going to count the bodies before we implemented it, I'm going to count the bodies after, and I'm going to compare the two. It's largely epidemiologic in nature, and we'll look at a variety of clinical outcomes. Typically, these are things like mortality and length of stay, and we'll look at a variety of economic outcomes, things like cost. And the archetype is sort of this figure I have on the left, right? We like to see that mortality was high, then we did something mystical and magical, and mortality decreased. What did we find? So we found a couple things, and Craig a bit touched on this, and I'm going to summarize, or at least sort of tell you the lens in which I view it, which is we found a lot of studies in which the sum total suggests pretty clearly that implementing telemedicine in the intensive care unit on average saved lives, right? We get a mortality benefit on average. But when you look at all those studies put together, and when you look at the study that we did published in Medicare that Craig showed earlier, I think the hallmark is not the improvement in outcomes. The hallmark is variability, right? That there's sometimes we implement this and things go fantastic. And sometimes we implement this and things don't go so fantastic. So what then was the limitations of that initial paradigm, this does this work paradigm? So there were all these methodological limitations, and I'm not going to go too deep into them. Suffice it to say that there's lots of reasons to be a bit skeptical of these before-after studies that we read all the time. There's confounding by case mix and illness severity. The statistical models that we have can only take us so far there. There's what I call coincident interventions, which is that we're making changes all the time in the ICU, and it's very hard to attribute the changes to a single organizational intervention. Temporal trends is just this notion that outcomes in the ICU are getting better all the time. And if we look in time period A and we look in time period B, we're very likely to see a benefit. And then there's this super wonky one called regression towards the mean, which is when you look one time and outcomes are bad, the very next time you look, outcomes are likely to get better. And this is just a sort of a classic pitfall, if you will, of before-after studies. Those are the methodologic concerns. But then there's these conceptual limitations to this research paradigm. They tell us nothing about heterogeneity, right? They don't help us understand why sometimes this works and sometimes this doesn't work. And then they don't give us this roadmap, right? They don't give us the way forward. How do we do this? So I'm pretty happy that I think for the most part, we've exited this research paradigm. And also in this talk, I'm going to press you guys to go back to your facilities, those of you who have implemented telemedicine, and do some of the fantastic research. But now I'm going to tell you what research not to do, okay? Don't do another before-after study of ICU telemedicine. I'm just going to repeat that. Don't do another before-after study of ICU telemedicine. We don't need to know if this works. What we need to know is how this works. We need mechanism. The only exception is here's the before-after study that I would love to see. I want to see a before-after study where nothing happened, there was no impact in mortality, or whatever your outcome is. Then you went and fixed something, and then there was an improvement in mortality. That's the kind of study that's going to drive the field forward. As Craig alluded to, we all got together, the Critical Care Societies Collaborative, and said, what do we need to do moving forward? This was now, oh my gosh, 8 years ago, time flies. And this is my favorite quote from this workshop. And I want to tell you, I've been to a ton of these workshops, and they're usually terrible, and I learned nothing. And this workshop was awesome, and I learned a ton. And everything I learned came down to this quote. I'm super proud of it. I probably didn't write it. The most important research questions are on how we use telemedicine, that's my emphasis, in the care of critically ill patients. The true value of telemedicine lies not in whether the technology exists, but how it is applied. That brings us to what I'm calling the current era of ICU telemedicine research. How and where do we work best? Telemedicine is a tool, and in the current paradigm of research, we need studies that tell us how best to use this tool. So, research in this paradigm looks a little bit different, right? We're past the sort of straightforward before-after epidemiologic studies, and we're into these multi-center, more context-sensitive, mixed method studies that use both qualitative and quantitative approaches. We've already heard about some of these quantitative approaches, right, where we survey multiple telemedicine units, and we figure out what the high performers are doing, and we've heard a couple things already in this talk, in this session rather, about what are the key motivators. I'm not going to show you the quantitative work, and I'm going to show you 2 qualitative studies, one done by our research group, because I think these give us a lot of insight into how best to use this potentially transformative technology. So here's a nice study from the VA. They looked at 7 hospitals. They did 97 interviews, super impressive. And what was really noticeable is the VA experience was largely a bit of a bust, right? If you look at the VA data, they published it in JAMA Internal Medicine, they didn't see a substantial improvement in mortality. Now, the VA has lots of other things going for it. In particular, one of the things is in this study, the VA mortality in their ICUs was already kind of rock bottom, right? It's a really high-performing health system without very high severity of illness. So it's perhaps not surprising that they didn't see a dramatic mortality reduction, but it's just kind of interesting to note. Now, what did they find? They looked at some key barriers to successful telemedicine, lack of understanding. Sometimes they would roll it out in ICUs, and the providers didn't sort of understand how it worked and didn't understand what it was doing. Nobody sold them on the expectations, right? Nobody told them what to expect. It ended up disrupting the workflows, and there was a lot of discomfort with being monitored. Some nurses felt that they were being spied upon. Then there are these facilitators that they noted. When they did better education and orientation, when they realized their expectations and then reinforced the expectations, meaning if I think something good is going to happen with telemedicine, something good better happen. and again and again. And if it doesn't, I'm going to get off the train. I'm going to feel like I don't like this technology. Things work well when workflows are very standardized, and things work well when there was relationship building. This is a really neat, well-done study that I encourage you to read. I'm going to offer you one quote, because that's the core of a qualitative study, right, is the quote. I think this was a nurse manager saying, before going live, get in and interact with the staff. Dial into the hub with the camera without a patient, go through introductions just like you would introduce a new staff member, right? Don't take for granted that people are going to communicate well over a remote system, right? I like to give the example of my mom. Talking with her over Skype is a real chore. I'm going to be honest. She has not figured this thing out yet, right? She doesn't know how to do it. There's tricks to it. You know, I end up staring at her neck because she doesn't have the camera right? You have to teach. Sorry, Mom. I love you. This isn't being recorded, is it? Okay. Let me show you the study that we did. This is in press at the Blue Journal. So it's not out yet in print, but you can go to the Blue Journal website and read it. We're super proud of it. This was funded by the NIH. It was a massive effort. Because it was such a massive effort, I'm given the credit where credit is due. Kim Rack, in particular, in the top left, is a PhD medical anthropologist. And what we did, led by her and her team, is we approached telemedicine like a tribe in a remote Pacific island, right? We essentially found some hospitals, we stratified them based on how good telemedicine was working in their settings. So we picked 4 telemedicine facilities that were really crushing it. There was a massive improvement in risk-adjusted mortality after implementation. We picked 2 telemedicine facilities that didn't have a significant benefit. Telemedicine was a bit of a bust in those facilities. And we went there for 4 days each, and we watched, and we observed, and we talked. We did 460 hours of direct observation. I say we. I didn't go on a single site visit. Sorry, Kim. But that could also be a bit good, as I was trying to justify her as I was pushing her onto a plane, which is that I have my own biases, right? I kind of feel like I know the answer to this. I'm the worst person to do these qualitative ethnographic approaches, right? Kim had no biases. She was really there just to observe. 460 hours of direct observation, 222 interviews, 18 focus groups. So what did we find? So after a lot of data analysis, we found that telemedicine works best when there has these 4 components. It's appropriate, it's responsive, it's consistent, it's integrated. And I'm going to take you through each of these. Appropriate means integrated to time and place. People want the care that they need, right? If it's a neurologic patient and there's a neurologic catastrophe going on, they don't want to remote in and get a medical intensivist. They want someone who has that neurological expertise. You have to modify the support that you provide to these people based on their location and what they have available to them. Responsive is you're there when you need it and you're not there when you don't. When you call the telemedicine, you better find someone who's willing, able, and happy to talk to you. When you put $1 in the Coke machine, you better get your Coke. If you don't get a Coke, you're not going to use that Coke machine again. If you have one bad experience, we found, that can poison it for the rest of your career. So you really have to have this consistency of service, which is the next element. Same level of service, same every time. It might not be important to you, but it's important to that remote team, and you better treat them like they're the most important person in the world. And then integrated. This is pretty self-explanatory, right? When care is disruptive, when care is delivered in parallel, right? You're doing your thing and they're doing their thing. It doesn't work as well as when care isn't integrated. We took it a step forward because we didn't really feel that was enough. So here's our conceptual model. You can see the 4 things that I mentioned: appropriate, responsive, consistent, integrated there in the middle. Those things lead to effective care, but we wanted to take even a step back further and say, what are the things that make care appropriate, responsive, consistent, and integrated? And I'm going to tell you those things, but I do want to take you through that feedback loop at the bottom. Staff perceptions, right? The better telemedicine works, the better telemedicine works. Every time you have a positive interaction, you get more use. And every time you get more use, it leads to more positive interactions. And I think almost any one of you who is a telemedicine provider, this hopefully should ring true, that the better it works, the better it works. It can be a vicious cycle or a virtuous cycle. These were the main factors that made it so great. These are what I'm calling the secret sauce, right? Some of these we found in quantitative approaches, such as Craig's study. Here we found them again in qualitative studies. We're coming at this from different approaches and learning a lot. Regular meetings, regular quality reporting, communication training. This next one was super important, and sites that did this really crushed it. Site visits and ambassador programs. So having the ICU team come to the box and see what's in there and get to know the people. Similarly, sending people in person to the distant sites in order to really create that communication and trust. Frequency worked, and frequent non-clinical interactions like education. And then attendings hated coming in the morning and find that everything was sort of mucked up. They loved being alerted that things had changed overnight so that there were no surprises. Some of these other ones are obvious: two-way cameras, shared staff. This was really useful. So if you have staff that work in both sides of the camera, it can help facilitate effective interactions, protocolized interactions. And then this was kind of interesting to us. So there's this one notion that you want to customize your services, right? So if you're a telemedicine provider, you might have a suite of services and different units can pick off the menu about what they want. We actually found that that's a double-edged sword. It's kind of neat from a customer service standpoint, but then it's confusing when you're in the box. What can I do in hospital A, and maybe I can't do that in hospital B, and it breaks down consistency. And so it was a bit of a double-edged sword. We found that it was good to have customized services, but not too many, and not in a way that it would kind of disrupt flow and integration. So now we have this specific roadmap, right? Now we have some real concrete guidance on how to implement telemedicine. And I think based on that original consensus conference, we've really come a long way. And I hope that we're going to take the next step and turn this research into something in the form of a guideline, an implementation roadmap that we can hopefully disseminate. That would be really fun. All right, in my waning seconds, let me tell you what I think the future is going to look like. What research do we need? And this is where I'm going to challenge you guys to go out and do this research, because I'm getting kind of old. I know that I have boyish good looks, but I'm getting tired, and I need you guys to start doing some of this fantastic research. Okay, so first we're going to need stronger tools based on organizational science and human factors engineering. I'm going to go in what I mean by that, and then we need to take in future research a broader lens. We're thinking too narrowly with our outcome measures. So what do I mean by better tools and better technology? Technology is changing. We're in the 1970s of television, if you will, in the current technology. We need research into how to make this align with the next generation of technological applications. These are going to be on demand, they're going to be mobile ready, they're going to be even more integrated with our EHR. We're going to have enhanced and virtual reality. I love the slide that Tim showed, and I show a slide of this too, where we all have the cows, the computer on wheels, right? And now when I'm on rounds, as the attending, I just see 6 computer screens. I don't even get to see a human face because everyone's behind their computers. It's terrible. Soon we'll have enhanced reality. The computer screens will just be around us, right? And we'll all be looking at the same thing. It sounds super high Star Trek-y, but it's coming. And we need our telehealth applications to be there ready for it. But don't sacrifice the humanity. Hans Jonas, a philosopher who's now deceased, humility is the antidote to the arrogance of modern technology. We need to still make sure that the new applications that we develop and the new science that we do is driven by need, right? We need to do these things because we have a problem to solve, not because we have technology in need of a solution, because technology can drive its own demand, right? When I was a kid, we got up to change the channel and we never had a problem. Now, if I can't find the remote control, I won't even watch television. It's too much of a pain. So technological determinism, this is called. We cannot let technology drive it. We have to let the problems drive it. Right? What's going wrong in my ICU, and how can technology solve this problem? And then lastly, we want to look at some new outcome measures, and there's 2 that I think we really need to focus on. The first is burnout. This is an FCCM statement that's in press, and we don't yet know the value of telemedicine in terms of its effect on burnout, but I think it's huge, right? And this is a real crisis in our community. It was alluded to in this New York Times article, which is now really old, But this is a great quote from this New York Times article. The doctors and nurses who work in this hushed office describe themselves as refugees from the chaotic pressures of real-life ICUs. And what it means, there's these two ways in which telemedicine could sort of help burnout. One is it can help me if I'm getting tired at the bedside, right? Being a nurse at the bedside, a physician at the bedside, that's really hard. Can I prolong my career if I'm sitting in front of a computer screen? And then, can we mitigate burnout by providing emotional support to nurses and physicians, particularly those in small rural ICUs, right? When I feel unsupported, when I'm overwhelmed, when it's the middle of the night and I have a patient that's too sick for me to care for, that's a recipe for burnout. But if I know that I have a safety net behind me, can I prevent burnout among that ICU clinician? So the next generation of research is going to focus on this outcome in particular. How does telemedicine mitigate burnout, and can we use this technology to extend the lives of critical care practitioners, or rather extend the careers of critical care practitioners? It'll extend the lives too if they get sick and end up in the ICU. One other outcome that has been depressingly unexplored in ICU telemedicine is end-of-life care. And this is really, really important. This is the only paper I could find, and it's a 12-paper case series, but it's super cool. And I'll show you one of the cases. It was a 50-year-old male admitted with respiratory failure. They called the academic medical center and said, we're overwhelmed. We need you to transfer this patient. They got on with a family teleconference to reveal that the history was more complex than they thought. Perhaps this patient was at the end of life. Perhaps they could actually provide palliative care close to home in the community hospital and avoid the transfer, which was happened. The patient went home to hospice and passed away in a way that I think we would all consider to be a good death. An expensive transfer was saved, and a lot of stress and strain was saved to the family. And I think we have, unfortunately, underexplored the use of this technology in terms of end of life. So this is, again, just to sum up, we started with, does this work? And I think we've answered this question, which is yes, but. It works, but in the right circumstances and when done the right way. Then we asked, how and where does this work best? And I think we're really lucky now to have a more specific roadmap about how to implement it, but we still have to refine it. And here's what I'm pushing you all to study more, is can we make this better? I think that's it. Yes, thank you very much. I appreciate it.
Hi, I'm Michael Ries from Advocate Aurora. I apologize about my voice, but I'll try to speak into the microphone, and if you can't hear me, just cup your hand over your ear and I'll talk a little louder. So it's an honor to be on the same panel as all these distinguished physicians and nurses. And what I'm going to do is take a little bit of a different perspective on summarizing how to get value, how to justify the cost of your Tele-ICU program and get value from it. And I think Jeremy touched on more of a standard concept of Tele-ICU being one product. And I think Craig showed the clinical benefits. Donna showed how to use the Tele-ICU to vertically integrate the technology to other areas of the hospital. And Tim really looked at using, I call it artificial intelligence, but being able to bring the problems to the forefront in a prospective manner. But I'm going to take the perspective of being a user, and we've been in Tele-ICU since 2003. We have 760 beds we cover, and Advocate Aurora is a 35 ICU bed system. And I'm going to try to point out that not every Tele-ICU is the same. And some are more costly, especially your initial expenditure. But even if you don't spend all the dollars that we do in the telemedicine programs that the other four panelists talked about, you can still gain value from the proposition. I have no conflicts. And at least for the talk today, I'd like to think of value being the importance, worth, or usefulness of something. But to understand it depends on who you're asking. And I think there are really 6 customers or 6 beneficiaries of Tele-ICU. The most important, obviously, is the patient and their families. And I think Craig showed some good data, and so did Donna, in terms of achieving those benefits. But there are other customers. There's the physician, and Jeremy talked a little bit about the burnout, the nurse, the administration who puts up the dollars. There's the regulatory agencies with their requirements, and there's the payers. So one of the key takeaway home messages I want to emphasize today is that a core function of Tele-ICU is to improve and standardize ICU processes by embedding it into the bedside workflow and making it part of your culture. This shouldn't be on both sides of the camera. Tele-ICU needs to be ingrained in the way you practice critical care at your hospital or healthcare system. I never felt that ROI, or return on investment, was a term you could use to capture the value of Tele-ICU, because a standard dollar amount can't be applied to the costs and the financial returns that are created. So instead of ROI, I really think of Tele-ICU in terms of VOI. It's a long list, and not every Tele-ICU program can recognize the benefits, but you can see that, and I've got this list from the literature, from our experiences, and from talking to collaborative colleagues across the country who've used Tele-ICU for the last 10 or 15 years. And I try to put them into buckets, but you can see some of those buckets overlap. And so length of stay obviously benefits the patient, but there's also some economic return from that. Adverse events benefits the patient. We can't easily put an economic value to that. And then some of them relate purely to the bedside nurse and physician in terms of avoiding burnout and extending careers. Again, the VOI, or the value on investment and financial return, will depend on the beneficiaries. And what you have to realize also that the benefits you achieve for one of these beneficiaries may actually be an added cost to the others on the list. So by providing benefit to these people, you may actually create some detriment to the others. So now we look back at the VOIs, and you can realize that each item on that list can have a different value depending on who the beneficiary is. I always rely on this Venn diagram. I've been using this since 2004, because where you create value, and I think Craig showed it in his financial studies, and Jeremy talked about it in his article that he alluded to with looking at research. Where you create value is by aligning the technology with your strategy. Your strategy is to deliver evidence-based practices to all your patients consistently. And the bedside flows, which are needed to, workflows, which are needed to carry out that strategy. Richard Thaler won the Nobel Prize in Economics in 2017. And he could have been talking about the Tele-ICU when he compared the psychology of economics to a gym membership. So Thaler proposed that it's necessary to view every individual as two people. The one that plans and the other that does or doesn't do what's planned. And the planner's side of you might see perfect sense in joining a gym and getting a gym membership at the beginning of the year with the goal of becoming more fit, losing weight, and extending your life. But the doer side of you might not follow the planner's anticipated goal. And if the doer, you don't use the gym membership on a regular basis, you're going to get no value out of that initial investment. And so if you don't use the Tele-ICU correctly, you're not going to get the benefits to justify the cost. So the whole concept is, it's not the technology whatsoever, but it's how you use the technology that creates value. I'm sorry. Now, we've been in the Tele-ICU business since 2003. And the use of Tele-ICU, at least across the country and in our system, has evolved over time. And it started out as a unifocal, faster response to acute problems, identifying deteriorating patients sooner. And then it's evolved into a multi-pronged tool that can actually help deliver evidence-based practices, such as Craig showed in his financial study, and the transfer of knowledge to lesser experienced nurses, either by training or helping residents at night when they're alone at the ICU rather than bothering their attending, or the nurse mentorship program where you have the least experienced nurses working at night where they can have a mentor in the Tele-ICU hub who've had 15 to 20 years of experience and help them work through their care plan and take care of their care issues. But it also can be leveraged, you can leverage the technology to other areas of the hospital, what I call vertical integration that Donna showed, and using Tele-ICU to deliver a better product to PCUs as they did at Baptist South, or to RRTs, or to the emergency department. And I'll show you a case at Advocate Aurora that garnered significant benefit. So the initial outlay of expenses will depend on the complexities of your system and the goals of what you want to achieve with your Tele-ICU program. For instance, do you want 12-hour coverage by your tele-intensivist only at night, or do you want to provide 24/7 coverage? Different initial startup expense. Do you need to upgrade your monitors, your computers, your servers when you start? And I'll show you a study that Jeremy and Dr. Kumar looked at the VA when they initiated their Tele-ICU program. Or do you want a centralized model with cameras in every room, or a decentralized model with mobile carts, which may make more sense for that small rural hospital without the financial resources that a large healthcare system like ours have available. So this was an early study where we looked at our first 4,100 patients. And we actually were worried because we found no mortality, no length of stay, and no cost benefits. However, once we drilled down on the 20% of patients where the Tele-ICU physician was given the authority to manage and not just monitor the patients, there were significant benefits to a reduction in length of stay and a reduction in cost. On the other side of the camera, in order to embed the Tele-ICU into the bedside workflows, you need to understand the particulars of the ICUs. Not every ICU is going to be the same. A cardiac surgery ICU is going to have different issues than a neuro ICU. It's going to have different issues than a medical ICU. And what you do for ICUs with 24/7 on-site intensivist coverage versus that rural hospital that has no intensivists on their medical staff will be very different. So there are basically three ways to evaluate the Tele-ICU economically. There's the cost analysis, or what the next best alternative was. And I can tell you when we started in 2003, our CMO and our CO said the best alternative to having Tele-ICU was 24/7 on-site intensivists. Not only did we not have enough intensivists in the system, but they looked at the cost. So the upfront cost, our initial capital investment, was $10 million. And that included upgrading some of the bedside monitors to interface with the technology. And the yearly budget to maintain the Tele-ICU was $3.5 million a year. The next best alternative was having 24/7 on-site intensivists at $45 million a year. A big difference. So their cost analysis justified investing in the Tele-ICU program. Cost effectiveness analysis looks at a single outcome, such as quality or safety or quality, but you can't assign a monetary outcome to a cost-effective analysis. And you can come up with a hypothetical quality, but that's not real-life experience. So the most comprehensive economic assessment of Tele-ICU is the benefit-cost analysis, where you can actually assess multiple outcomes, and those outcomes can be monetized. But to accrue all the variables is extremely challenging. And you can see that for each system or each hospital, there's a difference in what technology is available, what the objectives are, what the culture of the organization is. Now, when you look at the upfront costs, I think I referred to this already, Kumar and Dr. Kahn did a good job at identifying many of the costs that are required to establish a centralized Tele-ICU program. And again, you don't need to have a centralized Tele-ICU program because there are several programs in the country that use a decentralized approach, which is to use mobile carts, mobile cameras. And these are just the requirements that Kumar found existed at the VA regarding technology and staffing requirements. And he put some of the other initial startup costs or required variables into these buckets. And you have to ask yourself the question when you initially come up with what your startup expenses are going to be, 24/7 coverage from the Tele-ICU or 12-hour physician coverage. Do you want nurses in the Tele-ICU hub 24/7? And you can go down the list, but you can see how each institution is different. So the expenses incurred by your hospital, your healthcare system, is going to be very different than what other people experience and what's in the literature. Now, I don't want to be redundant, but Craig showed his study, and he really garnered huge financial benefits. But he didn't do it just with a Tele-ICU program. He did it by integrating the Tele-ICU program and interfacing his UMass Logistics Center, by changing the bedside team workflow to some extent, and then implementing new evidence-based practices, and I think Craig was 51 additional ones when you integrated these four components. And that became his critical care program at UMass. And he ascribed the value, and you read his discussion, he ascribed the value to the standardization of the processes. This was the culture of critical care at his system at UMass. I don't want to repeat what you said, Craig, but so the benefits, when you look at his table here, were largely due to increased case volume, higher case revenue relative to direct costs, shorter length of stay. And I think he alluded to the fact that some of the cost savings were attributed by a reduction of transfers from the community hospitals to the academic center. Study in the same year, though, from Mayo Clinic recognized an increase in the number of transfers from the community hospital to their quaternary facility. Now, perhaps theirs was a different strategy than they had at UMass. And their strategy may have been that they encouraged the more complex cases being transferred to the academic facility with less concern about leakage from their community hospitals. So again, as I said earlier, one of the key take-home messages is that a core function of the Tele-ICU is to improve and standardize ICU processes by just embedding it into the bedside workflow and making it part of your critical care culture. And I think one of the other things we've all found is that ICU telemedicine, when you incorporate it into the bedside workflows, proves to be a facilitator of change management. So there's not been one project where we've tried to integrate Tele-ICU into the bedside workflows, where we sit down with all the stakeholders to create a value stream analysis of that workflow, that there hasn't been some change at the bedside workflow to the benefit, to their benefit as well. Again, consider the beneficiaries, because it should always be the patient, but there are other benefits to your program. So what I did is actually, preparing for the discussion today, I canvassed several CMOs and COOs across the country from systems who invested in Tele-ICU. And interestingly enough, the rationale to invest in the technology was not primarily based on the monetary expectation. So I said that at Advocate in 2003, it was balancing the initial $10 million investment with a $3.5 million yearly budget versus $45 million a year, plus the fact that we didn't have enough intensivists to put boots on the ground 24/7 in every unit. Now, they all said that the most significant cost of critical care is the labor costs. Not one of them would ever consider using Tele-ICU to increase the ratio of nurse or physician to patient ratio at the bedside. But where they could identify or hope to identify some reduction in labor costs was, as Jeremy alluded to, increasing the longevity of their clinicians by extending careers, reducing burnout, avoiding sleep deprivation from the intensivist at home gets woken up with the calls from the bedside. What Dr. Buchman found at Emory by utilizing advanced practice clinicians, thereby in total avoiding recruitment expenses and the need to rely on locum tenens. And these are some of the other benefits, and how one CMO basically summarized it was, it's just the way we practice critical care at our system. And that's the way you need to think of Tele-ICU. It's not either side of the camera, but it's the way you practice medicine, critical care medicine at your site. Now, I try to put into buckets some of the benefits of the Tele-ICU to the physician. And one of them, interestingly enough, and it's fascinating, and I'm going to go back to my system and see how this can be put in place. But what you need to do maybe is use Tele-ICU to decrease interruptions by your bedside intensivists and nurses in their workflow. And the psychology of literature is well versed in the fact that for every interruption from a task that you're focusing on, when you're interrupted, it takes 20 to 25 minutes when you get back to that task to refocus. So when on work rounds, multidisciplinary rounds in the morning, you're talking about a patient, somebody comes up to that physician or that team and interrupts them, then they go back to thinking about the patient. They may forget to do all the evidence-based protocol delivery. They may forget some of the labs. They may forget to de-escalate antibiotics. So I think somehow we have to figure out how to decrease the interruptions of the bedside workflow. In terms of extending longevity, this is a typical hub physician pod in our Tele-ICU program. And Bruce here was one of the first Tele-ICU intensivists that worked in our hub. Back when we started, he had a full head of hair. Sorry to take your line, Tim. But he still has more than you right now, though. But what he does now is he still gives us a couple of shifts a week in the Tele-ICU hub, but instead of practicing 5 days a week in the hospital, he now practices 2 days a week in a much better lifestyle, and it's really extended his work expectancy. We have one cardiovascular surgeon who no longer wanted to do surgery, and she now provides us with 3 shifts a week in the Tele-ICU hub. And I can tell you, when we cover the adult surgical heart units, when I call in as a pulmonary critical care physician, what do they know? But when a surgeon calls in, now we got somebody who knows what they're doing. So I know this has been shown to you before. I can't remember who showed it, either Craig or Jeremy. But Emory found a $4.6 million cost savings to CMS in a fee-for-service environment by training and placing advanced practice clinicians at community hospitals with on-site intensivists during the day and a Tele-ICU intensivist backup at night. And they they recognized the cost savings by reducing 60-day readmissions and discharging the patients to a lower acuity post-hospital location. So here, of the 6 beneficiaries I told you to consider, beneficiary here was the payer. Now, there wasn't enough information for me to realize what the expense was to Emory, but here you got the payer as the beneficiary. So let me close by giving you a patient safety story in terms of garnering benefit from your Tele-ICU program. So this started out as a serious safety event, and one of our emergency departments, very busy, about 130,000 visits a year, very frequently would have ICU boarders in the emergency department waiting for a bed to open up in the ICU. And this was a patient came in, respiratory distress, was in the ED for about 16 hours, got transferred up to the ICU, realized that her non-STEMI required emergent cath, went to the cath lab, died 6 hours later. To us in our system, that was identified as a serious safety event. So the ED came and said, what can we do to avoid another serious safety event? Well, if we put mobile carts in the ED and have the Tele-ICU intensivists monitor those patients, because when we did a root cause analysis, we realized that the ED physician had multiple other patients to take care of. The intensivist in the hospital was up in the unit taking care of the other sick people. But now you could bring the tele-intensivist and the Tele-ICU nurse down to the ED to help monitor the patient and help support the management of that patient. Now, we talked about being a facilitator of change management. This was the workflow that we got all the stakeholders together, including the IT people, because even to cut labels for the labs required a change in the IT mechanics. But this took weeks, if not months, to develop a reliable workflow where there was reliable handover of the patient and there was accountability for the care of the patient. And even after we went live, this has been tweaked multiple times. So we achieved our goal. In the 3.5 years since we put this in place, we've not had one serious safety event. But lo and behold, you talk about the economic benefits. We found that by providing that earlier care to the ICU, to the ED boarder, 30% of the patients did not need to be admitted to the ICU. They could be admitted to a lower acuity bed. 30%. And when we looked at the cost savings, just in the first day of hospitalization, theoretically it would have been $662,000 for care for it was the first 130 patients. Not a randomized control study, and Jeremy would criticize me on that, but it was a real cost savings observation. But the initial day in the ICU would have cost $662,000. Those 30% of patients who now did not need ICU care created a cost of $230,000 at a cost savings to that one hospital of almost $450,000 by providing Tele-ICU coverage of their ED boarders. Interestingly enough, that over the years the capacity improved, and so now the same hospital came to us and they had a capacity problem with the telemetry or step-down patients. So we now cover the step-down patients, and interestingly enough, we still see the same 25 to 30% number of patients that no longer need step-down or telemetry, but can be admitted to a lower acuity bed. So I want to leave you with this question. With Tele-ICU, do the patients receive care that they would not have otherwise received? I'd hazard to say yes, but how can you monetize that? So in assessing the cost effectiveness of investing in a Tele-ICU, there's that initial concern about the value of the investment, the cost of the investment, but there's no guarantee that it'll be successful unless you use it properly. And as Voltaire said, doubt is unpleasant, but certainty is absurd. Thank you.